Okay, so what care are we giving in labor? We want to make sure we maintain attention to hygiene. There's a lot of fluid, mucus, blood, and things, so people start to feel kind of sticky and uncomfortable. So we want to make sure we're keeping the pads changed, allowing them the opportunity to clean up some. And allow food and fluids based on facility policy. So we used to keep anyone in labor, NPO, except ice chips. Now the trend is toward clear liquids. There's no evidence that that it's a risk. The reason we've kept them NPO is because of the risk of aspiration in case of general anesthesia. But needing general anesthesia for an emergency C-section is very rare, and so we're kind of moving toward it's less risk. There's less risk of that happening than slowing down labor because they're hypoglycemic or they're exhausted. So some facilities, some providers allow some food and fluids. It depends on facility policy. We're also paying attention to elimination. We want to make sure they're emptying their bladder every couple hours. A lot of women have had some diarrhea before they come into labor, so their bowel may be empty. If it's not, they may actually have to have a bowel movement. Sometimes if they have an impaction, that can actually impede descent of the fetus. So in that case, an enema might be helpful. We assist with mobility and positioning. Early in labor, a lot of patients want to walk around and move around. Later in labor, they may need assistance to reposition in the bed. We provide emotional support and support for coping with contractions. We also help family members provide that support. We would be assisting with the delivery and the supervising the immediate recovery. We need to be prepared in L&D for an emergency delivery because labor is not always predictable. So if you go into a room and the patient is in the process of delivering, or they're look as if they're about to deliver, there's some assessment that indicates they're about to deliver, don't leave them. Call for assistance, use the call bell, get some gloves on, and you want to support the perineum and have them pant or blow to try to slow down that delivery. We're not trying to keep the baby in, we're trying to slow it down to decrease the risk of tearing. If the head delivers, try to assess for a nuchal cord. If it's there, you can try to unloop it over the baby's head. If it's a tight nuchal cord, and it has to be cut for delivery, you clamp twice and cut between the clamps, but you got to be very careful not to cut the baby or the mom in that process. When the baby's delivered, you want to dry, warm, stimulate the baby, and then begin that neonatal assessment and recovery. You're also watching for signs of placental separation. After the placenta is delivered, we've got to maintain a firm fundus with massage as needed and monitor blood loss. The cord can be cut before or after the placenta is delivered. There's not a rush to get it cut. But if the cord is cut, it needs to be clamped twice with a cut in between. And don't use non-sterile instruments. Okay, tying the cord with a shoelace and cutting it with the scissors from behind the Walmart counter is more harm than benefit. So as a student, you should not be left alone with a patient that this is likely to happen to. So you should not be in this position as a student, but as a labor and delivery nurse, you will occasionally be in the position of having to deliver a baby. Pain management in labor. There are a lot of non-pharmacologic pain management options, movement, position changes, warmth, water, like being in the shower or being in a tub. Most of the time, you're not going to have a patient sitting in a tub after their water's broken, sitting in standing water after their water's broken. Massage can be helpful, counter pressure. So there are a lot of things that can help. Narcotic analgesics or opiate analgesics may be used in IV. Straight opiates are rarely used. Most often now we use a mixed agonist antagonist like butorphanol or what's Nubain, Spinal or Nubain. Okay, there's a risk of respiratory depression even with that mixed agonist antagonist, and that risk is actually greater for the baby If that patient progresses very quickly after a dose of IV pain med, the baby can actually have respiratory depression and have to have Narcan. They also don't give complete pain relief. They may take the edge off a little bit. And at some point, they start not to be very much help. We want to try to give that dose during contraction to minimize the amount that gets to the fetus. It depresses the fetal response, so you can expect to see a decrease in fetal heart rate variability. They need to be avoided late in labor to avoid neonatal respiratory depression, and neonatal naloxone should be on hand just in case of an unanticipated delivery. Patients may elect an epidural. An anesthetic agent or an opiate is injected into the epidural space. It can be a single injection, but usually with an epidural, it's going to be a catheter that's left in for continuous infusion. Epidurals can cause maternal hypotension because they can cause everything below that level to vasodilate. You can have hypotension. So usually we give a fluid bolus prior to the epidural being placed. They can affect pushing effort for some patients. Sometimes we need to just let them relax and labor down a little bit. They usually don't cause any respiratory depression for the fetus. They can make the bladder flaccid, so they're not able to void. So they might need a Foley. There's a rare risk of an epidural hematoma causing permanent spinal cord injury, and to prevent that or to decrease the risk of that, the anesthesia provider is going to want to know what platelets are, because if the platelets are low, they won't do an epidural because they don't want to cause that hematoma. There is a risk of accidentally puncturing the spinal cord. This actually sits right outside the spinal cord. If they accidentally puncture the spinal cord, that can cause a leak of cerebrospinal fluid, which causes a spinal headache. That can make the first day or so after delivery really difficult. Okay. If an epidural is in place and they need a C-section, they usually will first attempt to dose that epidural for delivery. Sometimes they can get adequate anesthesia for delivery or for surgery with that. If not, they may have to try an alternate method. An epidural would be contraindicated if the patient has low platelets or a bleeding disorder, if there's an infection at the insertion site. So if like they have a pimple right where it would be inserted, that's not a good option. Or if they have hypovolemia, if they don't have enough blood volume and we vasodilate with that epidural, their blood pressure is going to crash. We put them in spinal shock. Another option is a spinal or intrathecal block. This is most often used for C-section because C-section is more predictable. This is going to give them, this is usually a single injection injected directly into the subarachnoid space. They don't leave a catheter there. So if they did this for labor, they have to repeat it several times if labor goes on longer. So usually an epidural is for labor because they can leave the catheter in. Spinal is most often used for C-section. There is a risk of maternal hypotension, so they need a fluid bolus, just like with the epidural. Also can cause the bladder to be flaccid, so they need a Foley. It's contraindicated if they have low platelets or a bleeding disorder, if there's an infection or hypovolemia. So same things, right? Local anesthetics are used in the perineum if they expect to have to do an episiotomy, or if an episiotomy or laceration has to be repaired. General anesthesia is only used for C-sections in an absolute emergency. Okay, we're going to talk in the next section. We start talking about complications of labor.